Welcome to the 9th annual Saving the Brain Conference. I would like to thank the returning audience and hope that the new attendees and they find their day worthwhile. As before, the conference is put on under the auspices of Cottage Health with the direct involvement of the administrators, nurses, and physicians who identify with the Santa Barbara Neuroscience effort. We look forward to excellent faculty presentations, which I think will be of general interest to this eclectic medical audience. Today we'll hear from many speakers about what is working well in our current medical system, which is replete with as much technology as one might wish to have. However, I will use my time to remind us all what major challenges we have in dealing with the most expensive and in many ways most dysfunctional medical system in the world. This system organically evolved over a century ago, and I will argue that it is not suitable for our complex and high-tech ecosystem that we find ourselves in today. You might ask yourself, as an informed patient, even as a physician who is a patient or admitting someone who is their patient to a hospital, it sometimes feels like a lottery, because, and the question is why? Why is the answer, we don't measure outcomes, so we can't compare hospital A, B, C to D. We can't compare physician or surgeon A, B, C to D because we don't know their outcomes. All we know is what they say in their marketing brochures and what they act like in the office. Oh, he was a very nice man. He asked things about me and I really like him or her. But does that mean they're someone you want to entrust your brain to or your spine to? Not necessarily. I would argue that one of the major reasons we have a dysfunctional system is we lack transparency of outcomes and true understanding of the costs of care of the diseases we're treating. Most physicians, I think, are clueless about what each of their tests is costing to the patient. And every time they order a test, there's a cost. There's no skin in the game for them at this point. Therefore, they feel that they'd rather order the test than not, partially to protect themselves from litigation. So there are a lot of problems in our system, but I would underscore the point that I'm not trying to paint anyone as the villain in this story. We who deliver healthcare are all complicit. We all need to work together and develop a better system that's more cost-effective and where we can look at hard data to say that we're doing a good job. The data speaks for itself. I have no conflicts of interest to report. Why did we develop the Santa Barbara Neuroscience effort? I can tell you why I did, and that was to develop local neuroscience expertise in certain areas, not every area. We're not trying to compete with UCSF or Stanford or Cedars in every area. We can't. But there are certain niche areas that we can. And in some ways, we are better at delivering high-tech, high-touch medicine, which I think is, in general, better medicine. We've committed ourselves to educating physicians, nurses, and healthcare workers and patients. Several times a year, we have lectures at noon. We publish a magazine, all of which is designed to educate the regional healthcare workers about neuroscience issues. We've made baby steps in terms of measuring outcomes, not as much as any of us would like, but we're going to try to keep pushing ahead. Cottage has invested in a whole department of research under Dr. Richard Beswick recently, and we hope that this will light a fire under us and encourage those clinicians interested to develop a rapport with UCSB, a world-class academic institution right in our own community. I know Dr. DeLeo has already done this, and others have as well. Here's the problem we're confronting in this country. We're the brown. We're all the way at the top, and in these two graphs, that's not necessarily good. That means we deliver the most expensive health care on the planet by far. The UK and New Zealand are much more efficient in terms of cost per GDP percent. or cost per capita of patient. So you might say, well, we're spending a lot of money, but we're getting better results, right? And that's, unfortunately, if you measure hardcore outcomes, and we don't measure a lot, but we do some, like infant mortality in our country is not among the best, it's among the worst in the Western world. Here is a graph that says on the x-axis the different countries, on the y, a ranking of what's a mortality that was amenable to healthcare intervention. And we're at the wrong end of the spectrum here. So again, outcomes not good. If one looks at some of this data, here's another one, factoid. We're spending much more on pharmaceuticals in this country than anyone else by far, and yet to what end? Are we getting better results? Not that we can measure and look to. There are obviously bright spots, but we're not uniformly doing better. In fact, if you compare us to the OECD data, the group of which we belong, and the UK belongs, and France belongs, and Sweden, I think, belongs, we don't do as well as they. Here's one of the problems. You've probably seen this before. This is a nugget I've raked up several times. But we do pretty well until the age of 58 in this country. And this is an old slide. I'm not sure we may be doing better now, hopefully. But we do a bad job in terms of cost of care as people hit 58 and beyond. It's just astronomically different, asymptotically different. And there's got to be some explanation for this. Those of us who work in healthcare know there are too many people getting too much care with disease processes that are irreversible, that are hopeless. So we haven't educated our patients, their families. We haven't had them consistently state their wishes on durable power of healthcare forms before they develop their acute illness. We push too far, too long in an ICU environment and run up the bill. And since we don't have any skin in the game, we feel, well, it's better to do this because we don't know for sure what the outcome is going to be, and we don't really want to tell the family it's hopeless, et cetera. But we've got to confront this, or it's going to eat us alive. Some would say, well, if we just had a Medicare system like the NHS, where it was one insurance for all, we'd do a lot better. But look at this scattergram, where depending on where you look in the country, some people are getting what is reasonably good care for reasonably low per capita expenditure. Some people are getting poor care for large expenditure per capita. So it's all over the park. We're not doing a good job at Medicare either. And so Medicare for all is not going to solve this conundrum. We need to change the system fundamentally and how we're practicing medicine. So here's the pie chart in 2010. It's a much bigger number now. We probably have $2.8, $2.9 trillion going out the door to healthcare every year, up almost to 18% of our GDP. And we can't compare ourselves directly to Canada. Canada has only 35 million people in it. We have 39 million people in California. Canada spends roughly 200 million, maybe 215 million a year on their healthcare budget. 215 billion. So that's 100 times, less than 100 times of what we spend. The UK spends about 170 billion in the pound equivalency, and they have a much more streamlined healthcare system, but as Dr. Marsh will tell you, it's not perfect, and we can all do better. So I'm not telling you that there's a perfect solution to this problem. Here is a slide that shows how diseases that we treat have changed since 100 years ago to what we treat now. They're completely different diseases. And you can see that beginning in the 1960s, the cost for patient care began to take off. And I equate this to Moore's Law, Moore was the head of Intel at the time in '65 when he made his famous statement that the number of transistors per square inch on an integrated circuit would double every year, and so far that's been the case. Well, that's what we're seeing in medicine. Every year we're adding more high-tech medicine. We're doing designer drugs. We have drugs that cure hepatitis C, but at a cost of $100,000 or so a year. So we have to make some hard choices, and we haven't been making them well. At the SBNI, we have tried to collect outcomes. Dr. DeLeo's service, the stroke service, has done this since the inception, and that those outcome measurements have been plowed back into performance data that improve the way we take care of stroke patients in this region, and that has produced better results. There's no doubt about it. Dr. Park, who came in several years ago to take over the brain tumor and spine tumor surgery, has worked with Kate Musker and developed a bi-monthly brain tumor, CNS tumor conference, which is attended by neurosurgeons, neurologists, neuropathologists, geneticists, neuroradiologists, and every patient that's operated on is discussed, and not only discussed once, but as they process along, they're brought back up for discussion about what treatment changes should be instituted. This can only help their outcome, and we're very cautious about spending money for nothing. So I think there's no doubt that working in groups, working across specialty lines has helped us deliver better care. So why is this healthcare system particularly dysfunctional? Particularly in California, where physicians are not employed by hospital systems, we have an issue of a zero-sum game. If one person in the hospital wins, financially, other people, the physicians or the insurance companies, lose. It's like pushing on a balloon. There's no win-win. It's win-lose. And so we're working at cross purposes. We're not working in unison, and that's not good for the patient. Fee-for-service care, I hate to admit it, because that's what all of us grew up on, is not going to work in a complex system like ours, because the more you pay someone to do a service, the more service they're going to provide. It encourages volume care, not necessarily good care. And I think for all of our sakes, we have to get away from it. Capitation, where one is paid a lump sum to take care of a population of patients, leads to the opposite. You want more left at the end of the year to pay out bonuses for people, so you tend to undercare. And so it's not at all a perfect system. We are big in this country in episodic care. What does that mean? Let's say a patient has chronic or acute intermittent back pain. They're going one place one time, one place another time. No one knows who they're going to. No one knows what costs they're racking up. And so it's episodes of care rather than a continuum of care where people are monitoring the outcomes, monitoring the expenditure of money, asking the difficult questions, was this scan worth doing, et cetera. Here's an example of what happens when we're practicing zero-sum game and fee-for-service medicine. We tend in hospital systems to hold on to patients for treatment that we shouldn't be doing. We shouldn't be holding on to because we don't do enough of that particular case. We should be referring those patients particularly to high-volume centers unless we're going to increase our volume and expertise. So there are a lot of people being treated in this country at centers where they don't really do adequate volume. And it's been shown time and time again for procedures and surgeries, the more volume you do, generally the better outcomes you have. So that's a dysfunctional part of our system. So in comes Michael Porter. I don't know how many of you know Michael Porter's reputation, but he is a Harvard Business School professor. He's probably one of a handful of people in the world that is known for his expertise in strategy and business management, and he took a particular interest in healthcare reform. In 2006, he and Elizabeth Teesberg wrote a book, Redefining Healthcare, which I recommend as many of you who are interested in healthcare reform read. It really tries to pick apart our current system and as a businessman, reconfigure it to a point where we're getting value. And how does he define value? It's healthcare outcomes that matter to patients divided by cost of delivering those outcomes. And what is cost? It has to be carefully defined. It's not the actual expense of patient care. It's not the charges billed to the patient. It's the actual cost to the patient for a cycle of disease, let's say episode of congestive heart failure. It should be measured around the patient, not at the departmental level, not at the service unit level. Costs should be measured based on a condition that we're treating, so that we know the whole expense of treating that condition, and we can then compare apples to apples across different medical centers and even in other countries. Here's a way that people try to jury-rig the system. What is cost? We see charges, we see actual costs, we see input costs. It's very confusing, particularly if we're not accountants or businessmen. And so it's very hard to get to the kernel. What is the true cost of taking care of patients? It's a fraction of the charges. So here's Porter's continuous cycle of improvement methodology spelled out in pictorial form. Basically, he feels that if we have transparent outcome data and we analyze the variation between medical centers for treating a certain disease, and we identify current best practices, we then have that change our behavior, and we keep repeating that over and over again, trying to hone the expertise and rigorously compare ourselves to others and try to achieve more every year. So what does that look like in the real world? Let's say your father has prostate cancer, and they're in Europe, they're in Germany, they're going to look at this graph on the left and say, well, those two hospitals are equivalent. You know, whether I go to A or B doesn't make a difference. The 5-year disease-specific survival is the same. But what if you add more particular outcome data to that? There's a striking difference between those two hospitals that we wouldn't have expected. If you're a man and don't want to lose your sexual function, there's a clear choice. If you want to not have incontinence, there's a clear choice. But how would we know that walking into hospital A or B or C in this country? It's hard to get that data. There are some centers that are now offering that data, Cleveland Clinic, MD Anderson, some others, but we have to do better than we've done in all of our hospitals. Here's even more of information that's helpful to a patient decision. They're not only looking at outcomes, they're looking at cost per different type of treatment for prostate cancer. And so this is a very powerful tool that allows patients and referring physicians to make an informed decision about where they go for treatment, what appeals to them. You know, it depends on what they're looking at, cost, function, etc. So Porter has recommended that we develop integrated practice units, which is a big phrase, but it means, let's say, take a disease or take a symptom like low back pain, and you develop you put everyone who deals with back pain, from therapists, psychologists, to the surgeons together. You run each patient through a general evaluation. You acquire data. You see how the system's working. You reinvent it every year. And you begin to look at cost and outcomes. And you integrate this with a high-tech IT program like we've just put in at Cottage. And you can't help but do better than we're doing now when we have a hodgepodge of care. So here on the left is what MD Anderson used to do. On the far left, it looks like Brownian movement. The patients are ricocheting every which way depending on their preferences or the referring person's preferences. And what they've come to now is the blue, where patients are seen in a replicated environment by the by the core clinical experts, and then they decide which direction the patients move. This is the idealized world of MD Anderson, but it's led to better care. In Europe, they're setting up IPUs for breast cancer. They've specified that they have to have more than 150 cases a year. There has to be a clinical director who's responsible. It's multidisciplinary, et cetera. So they're working in integrated teams, all with the same goal: to refine outcomes, to measure outcomes, look at cost, and improve their performance year after year. This is Porter's concept, but others have run with the ball. Bundled payments, that's coming to us in the near future. Medicare will see to that. Bundled payments probably is theoretically a better way to go. We're being paid for caring for a certain problem, but also with performance bonuses based on how a patient, for instance, with back pain or lumbar stenosis problems, a year out, if the group that you're treating has done well, then you get extra money to the system. And then all the people taking care of the patient divide the check, right? Those are the devil's in the details, and I don't know the details. But on the left, you can see what happened in Stockholm with the bundled payment approach. The complications dropped significantly. The time in the hospital dropped significantly. And the outcomes stayed the same. So I think there's no doubt that it has something to offer, but I don't know enough about it at this point to say that it's the Holy Grail. Here are three wise men who've teamed together: Michael Porter on the left, Stefan Larsson, who's a MD PhD from Sweden, but he works in the Boston Consulting Group. He doesn't practice medicine. He gives an excellent TED Talk, which I've stolen from today. And then Dr. Ingvar, who's an MD PhD and was the head of neuroscience, was the head of research at the Karolinska. He's a neuroscientist. And they've brought their institutions, the Boston Consulting Group, Harvard Business School, and Karolinska Institute together. They've teamed with physicians and hospitals all around the world to conceptualize and make real Michael Porter's ideas. So here's what they're doing. And you can go online and look at ICHOM. And they are developing best practice sets for every disease of mankind. As of this year, they've categorized best practices for 45% of the diseases that are afflicting us. And I looked at the one on back pain. It's pretty powerful. They have looked at the whole literature on the management of back pain, and they've tried to come up with ideal best practice results that they've recommended that we use in our practices in our hospitals. And I think if we do, we can then compare the outcomes of our patients to those of hospitals around the world, and that can't but help us with our outcomes. So again, plugging in transparent outcomes data leads to a continuous cycle of improvement with hardcore measurements. There's no ideal system, but I think this is a better system than the one we're floundering with currently. I stole this from The Economist, this graphic, but I think we're all in sorry need of innovation. We've sat on our hands too long. We need to innovate and change the rules in healthcare, how we're delivering it, strip it down, reinvigorate it for the 21st century. We need innovation, but we also need inspiration. And this is a picture of the Channel Islands, which is 20 miles off our coast here. This is Anacapa Island looking west, and this is called Inspiration Point. So I think we're all in need of some inspiration and using that inspiration to innovate, using some of the tools I've talked about. Thank you.